Good morning. Thank you, Hilda, for your inviting me. And it is very nice to see youngsters like Hilda and Sanjana coming up with the instruction courses. Don't be disheartened with the audience, because so many people are interested in iBanking as such. Maybe different sessions are going on, that is why attendance is less. So the topic given to me is Path to Eternity, that is the iBank quality control and distribution. So I'll start with as Hilda said, the iBank Association Kerala, running in the CBM Ophthalmic Institute, Little Flower Hospital, started in the year 1970 as a small charitable society, and this was the first iBank in the private sector of India. Later on, there was infrastructure development, like we procured the laminar flow hood, we procured the intermediate storage media, the iBank specular, and the figure shows the evaluation forms, as Dr. David was pointing out. And this is in nutshell, this was the total 23-year collection data starting from 2001 to 2023. From 2000 till 2010, there was the volunteer collection were more, and the HCRP came into being from 2011 onwards, and you can see a steady increase except for the COVID year of 2020. And the changing strategies led to all these changes, like the slit lamp tissue evaluation by the doctors changed into the technician evaluation. HCRP tissue retrieval is being more followed up. Grief counselors in many collection centers, and many collection centers are also started in different hospitals and collection donation centers. Trained technicians are there. A proper SOP was constructed. Accreditation with the big organizations like SightLife was carried out, and there is a central tissue distribution scheme, and now the iBank is a more financially sustainable model. So this is the workflow of a general iBank. Like these four are the main pillars of the iBank. First is the donor acquisition, second is the tissue harvest and the preservation, third is the evaluation, and fourth is the tissue distribution. Not going into details because this has been dealt with in detail. Donor acquisition, mainly the two donor through the voluntary eye donation and the HCRP, and you need the counter signing by the next of kin, and specific documentations are needed. Also for the tissue harvest and preservation, by specially skilled and qualified personnel is required, and predefined steps executed in specific order in order to form a surgically acceptable tissues are needed. Then evaluation also, certain criteria, regulatory requirements exist for the test and documentation, and also for the tissue distribution. So tissue distribution, this is the model of tissue distribution followed by many iBanks. They are dividing the surgeon's priority into three. First priority, second priority, and the third priority. First priority, they call it as emergency priority also. If the patient is having a perforation or impending perforation, or if you have an emergency graft with good visual potential, and also in primary graft failure, they consider this as an emergency priority. Second priority being the urgent priority. If the patient is having pain, and for one-night patients and pediatric patients, they consider this as an urgent priority. Third priority is your routine keratoplasties. It can be neither emergency or urgent. It can be a unilateral blindness with good or poor prognosis, and also your elective cases of PK, DSEC, DMEC and all. This comes under the routine priority. And the tissue distribution is according to the surgeon's request. The surgeon should place a request to the iBank indicating the patient's details, what is the diagnosis, what is the need of what is the indication, and the type of the planned surgery, what she or he is planning, and the tentative date of the surgery. And when the distribution is prioritized, wherever the base hospital, those needs are prioritized first, and then if the in-house need is not there, then they will distribute to the same district. That means in Ernakulam means they will give it to the Ernakulam district, and if there is no need from the same district, other districts will be considered, and if there are no needs from the other districts, then the tissue will go outside your state. And whenever the tissue is sent, this type of label will be there on the vial, stating the tissue ID, the time of death, the preservation date, expiry date, and so on. But a set of universally accepted indicators for the quality assurance in iBanking is not available until this article came. Every iBank is having a paradigm shift nowadays. Rather than collection, more emphasis is given on utilization of the tissues. And this can be used by the usage of the intermediate corneal storage solution because of the shelf life can be increased. And you can have elective surgeries. From the charity model, the iBanks are raised into a self-sustainable model, and also expansion of the functions like preparation of pre-cut tissue, DMEC role for the component corneal surgeries. Once your iBank is established, once you have enough utilizable tissues, you can expand the functions of the iBank, and also the bioengineered cornea. Many iBanks are working on that. So quality assurance, why is it essential? The quality assurance program is necessary to ensure the timely availability of corneal tissues to the surgeons to enhance the effectiveness and the efficiency for the safe utilization of the tissues as well as the infection control. So these are the requirements for the quality assurance and the quality control. A proper SOP is required. Review of the donor records periodically. Any adverse reactions should be noted to the iBank. In case of adverse reactions, a tissue recall and withdrawal should be practiced. And any departure, deviations, or non-conformance to the SOP, you have to have a CAPA action. That means corrective and preventive action has to be carried out, and also a regular, periodic, internal and external auditing. These are examples of SOP or the standard operating procedure. Each iBank should mention in the SOP what are the definite criteria, the criteria for the tissue retrieval, for the evaluation, storage, distribution. Everything should be described well in the SOP, and that should be followed. Review of the donor records. These are examples of the record keeping. The record keeping is very important in iBanking, and also this is the adverse reaction form. This will be sent to the surgeons, and if there is any adverse reactions like infections or primary graft failure, this should be filled up and this should be returned to the iBank, so that the iBank can go into the details. And quality analysis and the quality is important in the quality assurance program. And this there are these 4 points: the environmental monitoring, complaints and reporting, performing investigation, and in case of positive serology also investigations. Errors can happen in the quality assurance within the iBanks. There are 4 different levels errors can happen in man, machinery, process, as well as policies. In man means sometimes there will be a new fellow or a newly hired staff. They won't be knowing the tissue evaluation properly. So the proper tissue evaluation and the proper contraindication should be mentioned correctly and should be stick to the wall where everyone can see and refer to that. And machinery also, for you have to maintain the correct storage transport chain. Any malfunctioning storage refrigerator can also lead to tissue damage. So the correct internal temperature should be maintained. And process also, the procedure for retrieval of the corneoscleral rim as performed described by Dr. Vinay, and maintaining the adequate cold storage chain during the tissue transport is also crucial. Policies also is very important. Well-established policies and guidelines for the tissue retrieval and the distribution to ensure the maintenance of the quality standards. So I will describe 3 case scenarios where you can go wrong, where you can do this CAPA, like death preservation time. So in case we are strictly dealing with the 6 hours time, but in haste somebody will be hearing the death must have happened before time, maybe 16 hours. 16 hours after death, the technician has received a call, and by mistake he has heard 6 hours. So unnecessarily they went to the scene, and that tissue could not be used. But then that investigation should be conducted. And also case 2, medical reports and blood sample collection. Sometimes the team or the technician will forget to have a blood sample collection. So in that case also, the serology you cannot do, and that tissue cannot be used. And also sometimes by mistake they will be keeping these tissue vials in the freezer. Then also that will get crystallized, and in that form you should have a kappa, like you should completely, you should have a proper investigation of what has happened in each case. So the continuous quality improvement can be achieved by identifying the implementing corrective actions, develop policies and guidelines to prevent recurrence. Once happened, it has happened, but you have to develop policies and guidelines to prevent the recurrence. And good clinical practices can be established, ultimately benefiting the patients. So these are the quality indicators which are mentioned in this very good article by Manisha Acharya. The 4 quality indicators for IBank are the adverse reaction rate, the discard rate, protocol deviation rate, and the compliance rate. Thank you.
Thank you, madam, for the extensive presentation with all the beautiful points. The complexity of the topic has been broken down and very clearly explained.